Well, hello and welcome back to World War II TV. Did you miss me for those 3 days while I was away? I hope so, but we've got a cracking week coming up for you now when we're looking at medics, but beyond that, the role of the medical branch in World War II. We've got some great presenters, great shows coming up for you this week. But today we're starting with a kind of a technical look at the role of American surgeons in particularly the Pacific theater. So I'm just warning you, it's in the description below, but there are going to be a few rather graphic images of combat injuries, so gangrene legs and things with bits hanging off them and nasty colors and things. So if that kind of thing offends you, then I would suggest you watch come from behind the couch or something, like watching a scary film. But it's imperative to cover some of this detail, because this is going to be a really good examination of the way the US military looked after its seriously wounded in World War II. So that was my warning done. Without further ado, I'm going to introduce my guest, and I've got an absolute combining of both fields now, military historian and medical doctor. So joining me from the States, Dr. Thomas Helling. How are you doing, Tom?
Good. How are you?
I am very well. So you wrote this rather cracking book, amongst others, The Agony of Heroes, which the link is in the description below. So you are a practicing professor of surgery. That is your day job. Where did the interest in the World War II side of the medical sphere come from?
Well, you know, in surgery, I've always had an interest in trauma, an interest in injuries and how they're repaired. And again, some fascination with the military ever since childhood, I believe. So I think I kind of married the two, and turned out that I found the military surgical history quite fascinating. I think it speaks to many of the advances that have occurred in surgery over the decades and even centuries that have resulted in the saving of lives and limbs because of those experiences. So I just think it's a major part of military history and a major part of medical history, quite frankly.
Well, having read your book and having done the prep I've done for the shows this week, I would agree with you. But I think it's a lot of the people watching will be very understanding of the fact that aviation technology developed dramatically in World War II, tank technology, weapons technology, camouflage, ballistic rounds, all those sorts of things. But I think we don't pay enough attention to the developments with the medical side of things and how we went from not a primitive way of treating things, but during those 6 years of warfare, huge advances were made. And as you said there, and we will elaborate on the show, many more lives were saved because of these developments that were brought in by we're focusing on the USA tonight, but the British and Canadians and the Commonwealth as well. And I would love to do in the future a show about the German or the Japanese side of things with regards to the medicine, but it's finding it a bit tricky to find the experts in that subject. But anyway, as with all my guests, Tom has provided a PowerPoint presentation. This is where some of these graphic images will be. So I'm going to kind of hand over to Tom to explain the background of what we're going to be talking about, and then I will interject, as I always do, with my comments and indeed questions from you guys watching. If you have questions about how things were developed or anything you want clarifying, just ping me and we will do it. Antibiotics has already come up in the sidebar there as something we'll talk about. But I'll hand over to you, Tom, and then I'll interject when I feel it's needed. So over to you.
Good. Thank you. Well, listen, the whole premise of my presentation is focused on getting the surgeon and the injured patient together as soon as possible after injury. That's the key. And that principle was not new in World War II. It actually started in World War I when injured soldiers were treated at the front by daring surgeons who rushed towards the guns, as it were, and began treating patients. And this principle really developed in popularity during World War II. If we can see the next slide. So the principle now we call damage control surgery. And like with any damage control, it means trying to limit the amount of devastation by intervening early. And damage control surgery means surgery to immediately correct life and limb-threatening problems. We do this in an expedited fashion to stabilize the patient so they can be transferred to areas in the rear where surgeons can more leisurely or safely fully repair the patient. So next slide. In other words, the concept itself was developed by a Harvard surgeon by the name of Edward Churchill. His quote here, "The initial surgery of the forward area," meaning near the battlefield, near the front, "is primarily directed towards the preservation of life and limb. The immediate physiologic disturbances, such as blood pressures and heart rates and level of consciousness, was incident to blood loss and needed immediate correction." So if I could have the next slide, basically that means stop the bleeding. Hemorrhage is, of course, the major threat to the injured soldier, and the sooner we stop the bleeding, the sooner the soldier's physiology can begin stabilizing, and we can thus more safely transfer the soldier out of the battlefield area to hospitals in the rear where treatment can proceed. So next slide. So Churchill's concept, and I'm going to use these terms in the next few slides. Churchill's concept was what he called resuscitative surgery. And that is basically damage control surgery. That's done quickly after injury, or at least as quickly as possible. It's primarily concerned with stopping the bleeding, controlling blood loss, controlling tissue damage and contamination. He then uses the term repair surgery, which is more or less the final repair of all injuries. So resuscitative surgery is done as early as possible. It's supposed to be abbreviated, so not a lot of time is wasted in repairing some of these complex injuries, but only enough done so that the soldier, the patient, can be safely transported off the battlefield and back to general hospitals. Reparative surgery is the type of surgery done at the rear area and is concerned with the sometimes elaborate repair of complex injuries. So let me have
just to jump in, Tom. We've had a question from Norma Graham now. Who is Edward, or who was Edward Churchill, and what made him visionary? Because, and by the way, it's lovely to talk about a Churchill being important in World War II that isn't the big famous one. It's nice to have another Churchill.
Right. Yes. Well, Edward Churchill was a surgeon at Harvard University in Boston. He was an extremely talented individual and also a very compassionate person, a true patriot. At the start of the war, he was selected as a consultant in surgery in the European and Mediterranean theaters. He simply was one of those few individuals who seemed to be at the right place at the right time with the right skill set to realize that repair of these damaged men needed to start very, very early. So, and he, after the war, went back to Boston and had a brilliant civilian career as well. Truly one of the masters of surgery in the United States. So if I could have the next slide. Could have the next slide.
I'm just got the internet flutter for the moment. Should be back. Here we go.
So now this is one of those graphic pictures that I wanted to show because I wanted to demonstrate what kind of injuries we're talking about. We're not talking about simple bullet holes or a simple fracture. These military injuries from weapons of war during World War II were devastating injuries, producing a lot of tissue damage. And the point I'm going to make is that at first, particularly in the Pacific Theater, these injuries were brought from the battlefield to physicians who had almost no surgical experience sometimes, and certainly no experience dealing with the magnitude of injuries such as this. So this was the true challenge in the Pacific Theater of Operation in trying to get these poor soldiers and Marines cared for expeditiously and effectively. So if I could move on to the next slide. Now, this portrays the usual flow of events after injury at the time of World War II. We call it echelons of casualty care. The first person on the scene usually would be the corpsman or the medic. They delivered first aid on the battlefield. They applied tourniquets. They applied pressure if that was useful in controlling the bleeding, and they immobilized the soldier or the Marine enough to drag them back from the front to some type of aid station a little bit further to the rear. And that aid station, at least for the American forces, was called the battalion aid station. Again, a physician was there, and that's the first time on the battlefield that the wounded soldier would encounter a physician. The physician did basically first aid as well. He would start IVs, give blood or plasma, try to control bleeding if it wasn't controlled, and facilitate the removal of the soldier, the patient, off the battlefield to more elaborate facilities. The next echelon of care then would be a clearing company, basically a field hospital. They may have had some surgical capabilities in that they may have had some surgical equipment. The physicians there may have had some surgical experience, and that might have been a place for what Churchill called resuscitative surgery, what I'm calling damage control surgery. And so that was ideally, and I want to emphasize the word ideally, that was ideally the first place on the battlefield that the patient could receive surgical care with some degree of skill. The plan was then, once that was completed, to evacuate the patient to what we call an evacuation hospital, which was a more elaborate hospital and did have skilled surgeons, maybe even subspecialty surgeons available to start the reparative surgery that would eventually, hopefully, produce a fully recovered patient. Then, of course, to further rehabilitate, the patient would be transferred to a general hospital in safe rear areas or even back to continental United States. So I want to emphasize that this is the ideal plan. The entire spectrum of events, as you see, from a first encounter with a corpsman or a medic to the evacuation hospital, was thought to be in the range of 8 to 12 hours, ideally. That was not, however, what happened in the Pacific Theater. If I could have the next slide. You can see here, this is the Pacific Theater of Operations in World War II. And I have red circles indicating the larger hospitals that were available to start what I have called reparative surgery, which means a sort of a definitive repair of these complex injuries. Otherwise, the wounded soldiers and Marines were scattered throughout the battlefields of the Central and South Pacific with really very little ability to safely transport back to these areas circled in red where there would be skilled surgeons. So their care until that point was at first in the hands of physicians with very little surgical training. So let's have the next slide. So the challenges in the Pacific War were unique. Because of the distances involved, the injured soldier, the injured Marine, was at the mercy of a very slow transport system. The other additional challenges were that the battlefields were very small. Many of these islands were invaded by amphibious operation. There was really little ability or little space to set up surgical hospitals on the islands themselves. Also, there was the very real problem of treacherous evacuation from the battlefield, rugged terrain, enemy action, and even if we got the patient back on ship, there was no guarantee of a safe transit to rear areas that were sometimes a couple of days away. The enemy had control of the air in the early phases of the Pacific War, and submarine activity under the water was still a major threat. So the Pacific theater presented some unique challenges that really were not in the medical game plan at the start of the war.
So just to jump in, the Pacific issue was particularly something the USA faced. I know the British Empire is in Burma as well, but it's the distances of doing the iron hopping campaign. But I'm thinking about other World War II TV shows we've done where we've talked about tank development in the 1920s and 30s. And we know, of course, about, the Nobel Prizes for medicine. In that interwar period, I'm going back a bit, how much collaboration and cooperation was there between the USA, Great Britain, Canada, Germany, and in terms of battlefield medicine? Was each country kind of thinking about it in their own independent way?
No, I think in Europe there was a lot of collaboration among the Allies in developing frontline medical care. In the Pacific, it was mostly, at least in the Central Pacific, mostly a United States operation. I think many of the modifications in the flow of casualty care in the Pacific were done by the United States. There just simply wasn't a great deal of Allied input at that point.
Okay, good. Whoops.
So if we could, yeah, go. So let me summarize then the echelons of casualty care in the Pacific theater. I've kind of modified that previous slide. Obviously, one still had the corpsman or the medic at the edge of the battlefield. They were always present. They did a fantastic job encountering the wounded, dragging them back to some semblance of safety, and starting first aid. There was still the battalion aid station, even on these small island amphibious operations. They were set up under some kind of shelter, whatever they could find. Physicians were still present there to deliver plasma and blood, intravenous fluids. However, not very often were there surgical field hospitals set up. The land mass was oftentimes simply too small for that to happen. So that from the battalion aid station, in many cases, the casualty was shipped offshore in whatever conveyance they could find. And the first encounter with anybody with surgical ability or any facility that had surgical tools would be the ships afloat. As it turns out, and I'll talk about in a minute, actually the transport ships that brought the Marines and the soldiers in were the first ships to receive casualties because these Navy personnel and their landing craft loaded with casualties, they really didn't know where to take these people, so that the best place they could take them was to the ship from where they came. And those were usually the transports anchored a significant distance offshore. And that's where not only resuscitative surgery began to take place, but in many cases, some attempt to definitively repair the injuries. Base hospitals, as you may have seen on that previous map, were sometimes thousands of miles away and maybe days in transit. So whatever was going to be done to save that soldier's life, to save that Marine's life, had to be done either ashore or on those transport ships anchored offshore. You might ask, well, what about hospital ships? For the early years of the war, 1943, maybe much of 1944, hospital ships were not deployed. It was simply too dangerous for them to be anchored offshore. They were at the mercy of Japanese air and Japanese submarine activity, if not the immediate threat of Japanese surface vessel activity. It was not a very secure environment in the early amphibious campaigns, as you probably know. This is what we were faced with in terms of damage control surgery. physicians aboard the attack transports were responsible for receiving these folks, for stabilizing them, for doing this resuscitative or damage control surgery, and trying to somehow get these injured soldiers and Marines safely back to areas in the rear that were a few days away. Again, let me stress early on in the war in 43 and 44, there was no air evacuation. It was just about as foolhardy as trying to send hospital ships to the amphibious site. Air transport was simply not possible. It was too dangerous. So if I could have the next slide. Yeah. So what was the alternative? Well, the alternative was, since we couldn't bring the soldier to the surgeon, some people thought, let's bring the surgeon to the soldier. And if I could have the next slide, what exemplified this best was a surgeon by the name of Percy Carroll, who devised the portable surgical hospital. And this was the first type of what we now know as MASH unit, first type of mobile surgical facility. And he utilized this particularly in the WWII Campaign in New Guinea in late 1942. He would develop a very portable hospital. If I could have the next slide. Well, I want to say what he felt about what he initially saw and why he decided to embark on this initiative. He told General George Marshall, the Army Chief of Staff, he said, I was up there and saw these boys, sometimes abdominal wounds, chest wounds, legs almost shot off, and hemorrhage, and so on, and shock. And I said, I want surgery in the front lines. I want surgery where it's needed. And Marshall gave him as much support as he could possibly give. And if we could go to the next slide, it shows you where he would want to insert his portable surgical hospital. It would be right up there where, right behind the battalion aid station, very close to the action, frequently under fire from enemy guns. So it was not necessarily a safe place to be. Nevertheless, Carroll felt that the patient needed immediate surgical attention, and he found young, ambitious, and courageous surgeons who had enough skill to move up to that location and begin treating the injured patient. So I have some pictures of that on the next slide. Well, before we get to that, here's the type of patient that oftentimes field physicians encounter near the battlefield. And you can see that this is a very complex situation. You see at least a 3-limb amputation. If you can see, there's a midline scar on the abdomen, which means that they had already done operations on the abdomen to repair internal injuries. These are the types of injuries that these physicians encountered at battalion aid stations and at casualty clearing stations. They were not simple injuries. They were survivable, but they needed expeditious care. And if I can have the next slide. So here is an example of Carroll's portable surgical hospitals. He used them in the Southwest Pacific. He also used a few in the Burma campaign. You can see in the top left the doctors and members of the team were actually hand carried the equipment in. Obviously, some of these sites where they set up the hospital were extremely remote. They were near the battlefield in the jungle. And you can see on the slide right there, you can see the tented hospitals and the open air environment where these patients were cared for. They were placed on stretchers right on sawhorses in the tents, and the surgery began. And you can see the primitive conditions of the surgeons on the slide to the right. The scrub sink, as we call now, was really a scrub basin with soap and water, and then they were ready to go. So, and these, if I can have the next slide, these were remarkable facilities in that their ability to salvage the injured patient was remarkable. So very effective organizations. They would help develop what we now know as mobile surgical hospitals or MASH units.
If I can jump in for a second, Tom, because I like to jump in for a second. So the graphic injury photo there, I know that's a modern photo, not a wartime photo, but there were, if I remember correctly, there are 3 medical staff around that victim there. So how does the American military, and indeed all militaries, balance that risk of you're putting a surgeon in the front line there? You've already talked about the fact they're in constant danger. Now, I guess you're going to talk about how much training these surgeons have had and how many years have been spent putting them into a position where they can offer this kind of care. But one stray errant artillery shell, one enemy dive bomber, and you've lost people you can't replace. So I understand saving the lives of soldiers is important, but at the end of the day, that soldier's life, he's easily replaced on the battlefield. A surgeon isn't easily replaced on the battlefield. So how does that kind of dynamic work? How do they decide where the priorities go?
Well, I think that's an excellent question. I think you have to weigh the balance of safety versus expedient care. And these hospitals were generally, I mean, not within yards of the firing line, but they were probably kilometers from the firing line, far enough away so as to minimize direct fire from the enemy. Although not always. Some of these portable hospitals were actually under attack by infiltrating Japanese. And so it was not entirely safe, even though they were not right at the fringe of activity. But you're right. I mean, that was the dilemma. How far forward can we put trained surgeons who have some value because of their expertise and are limited in number before we actually risk their lives? Now, the other issue is, and I'm glad you raised this question, the other issue is patients themselves, if they're too near the front, become absolutely unhinged by the proximity of explosions and gunfire, and psychologically is ruinous to them to be that close. They've already suffered an injury, they are helpless, and they feel that if they hear that kind of activity close by, they feel that they are so vulnerable as to be at the mercy of the enemy. So it's not really advantageous for either surgeon or patient to be too close. It's a matter of determining, though, what that closeness will be. And generally speaking, it is far enough away so as to be outside the range of direct fire. Yeah. That's to say they weren't susceptible to artillery and mortar fire or air attack, but at least as far as direct fire, machine guns, small arms, maybe even mortar fire, they were far enough away to be outside that range as a rule.
But the other thing that is worth discussing is also the morale effect of a soldier in theatre, in that they all want to think that if they do get hit, they're going to be treated quickly. You will fight as a more efficient unit, whether you're American, Canadian, or British, if you feel you're going to be taken care of quickly when you die. I always talk in Normandy as my day job as a battlefield guide, when I've talked about how quickly, for example, the British sent out parties to recover the dead and the wounded from night patrols. And they're going into enemy territory again. And it's because everyone wants to know that if you get hit, you will be looked after immediately. It's part of why you're prepared to take the risk. You'll take the risk if you know someone else will take the risk to get out of there. So that's a very difficult thing to measure. And so you can't measure the morale of an army in combat. But by the way, when you talk about Buna, I should point out, viewers, we've got John McManus coming on in July to talk about the Buna campaign in 1942. It's his favorite, quote unquote, early Pacific campaign. I think it's one of those ones we don't know enough about. So watch this space. I'll announce that one when I've made the arrangement with John. But he wrote about that in his first book, Fire and Fortitude. So that's coming up later on, folks. But I'll hand back to Tom now.
Well, those are good points, and let me stress while we're talking about that the admiration that I have for medics and corpsmen. They are of immeasurable benefit to the morale of the soldier. They will almost invariably risk life and limb dragging these wounded soldiers and Marines back to safety. When you look at the Medal of Honor winners, many of them won that award, that recognition, because of their selflessness in retrieving and recovering wounded casualties.
Absolutely.
And what else is important to morale, I must add, is the proximity of surgical care. If a wounded soldier or Marine knows that they will be tended to quickly by their fellow medic or corpsman, and knows that within a short period of time they will be in the hands of a surgeon, it is extremely beneficial to morale, and it is something that may sustain the fighting man, at least during World War II. So, but anyway, moving on, I want to talk a little bit about the Central Pacific. If we could have that previous slide. I'm going to focus now on the early campaigns in the Gilbert Islands because they illustrate some of the problems that the Navy encountered during their first amphibious campaigns. And I'll speak specifically of the Tarawa campaign in November, I believe, of 1943. If we could have the next slide. So this was the Echelon flow of casualty care in the Central Pacific. Of course, the corpsmen, the medic were still present. They accompanied the invasion troops on the beachhead. The battalion aid stations, of course, would still be set up. But then without any other hospital facility able to be established on shore in some of these small islands, like in the Gilbert Island campaign, the patient would be triaged offshore to transports. And there the resuscitative damage control surgery would be started. Later in the war, hospital ships were in fact utilized during the Mariana Campaign and afterwards, and were a measurable benefit to the wounded Marine and soldier. Then the patient, of course, was transferred to the base hospital. So this is the flow of casualties for amphibious operations in the Central Pacific. Now, when you look at encounter with the corpsmen to triage offshore, we're still looking at a time delay of about 6 to 12 hours. So next slide. So this is the Tarawa campaign, and I think many of you are probably more familiar with that amphibious operation than I am. But when you look on the top picture, the entire Tarawa atoll, you can see that the transport area that I have depicted off to the left, is a significant distance from the landing beaches at Badio, which is the major and the bloodiest campaign of Tarawa. So we have a smaller picture again. Obviously, the Badio itself was so small that there was no ability to have any kind of fixed hospital facility. There was no safety from indirect fire on that island. So once the patient was stabilized, they had to be shipped offshore. And if you could minimize that slide a little bit more, from beach to transport area and surgical care was a distance of 10 miles. Not an insignificant distance to be loaded onto a landing craft, cross a reef, and out to open sea to get to the transports. So quite a challenge. Now, next slide. So this is what happened on Badio Island in November of 1943. You see on the left-hand picture a picture of a Navy corpsman attending to the wounded. The corpsman then loaded the casualty onto a rubber dinghy, and under fire from the Japanese, kind of shifted the dinghy out to the reef, where they were then loaded onto a landing craft, and then the landing craft took them to whatever transport they could find. There was no rhyme or reason. Sometimes they took them to nearby destroyers or other warships, whatever they could reach. Frequently, they had on board soldiers and, well, Marines in this case, who were literally dying. And the urgency they felt to get these casualties out to somebody else was significant. So a number of transports were involved in the care of these casualties. A few destroyers were involved in the care of casualties. They were staffed by physicians who had almost no surgical training, yet they had no other choice than to try to save these lives. So a remark, and they did pretty well. They did pretty well. The death rate was low, and it's remarkable that these physicians with so little training were able to care for such complex injuries. So now this is an example of one of the attack transports in the Gilbert Island campaign. In this case, the USS Sheridan. And if you can go to the next slide, it will show you this is not what we would think of as a modern operating room, but this is it. This was the officer and crew mess that doubled as the operating room and the hospital. And there you have it on the lower picture there. That's the operating table next to some bunks, and that's what they used. And by our standards, maybe terribly primitive, but somehow it worked. And there was nothing else they had to offer these casualties except that. So, and next slide. So this was a comment by Lieutenant Commander, a Navy physician on board the Sheridan, a gentleman by the name of Milton Small, and he said, in recalling this experience, he said, the majority of these cases were serious wounds of the head, the chest, the abdomen, fractured and shattered joints. Each man was quickly and thoroughly examined and x-rayed, were deemed advisable. Practically all cases were treated for shock by large volumes of plasma, whole blood, and intravenous fluids, as these cases had been exposed to severe hardships for several hours, as we talked about, due to the inability of evacuation from the beach to the ships. Now, this was not a pre-planned scheme. As you might recall, the Marines thought they would walk into the Gilbert Islands, into Tarawa Atoll and its islands, and basically occupy the island. They felt there'd be very little Japanese resistance, and we know it was one of the bloodiest operations of the Pacific War. So I think every physician was caught off guard by this. I think the casualty evacuation scheme was overwhelmed. There were delays in getting seriously injured patients back to any place that could take care of them surgically. So it was quite an experience.
Now, when you said physician there, what level of training and what experience are we talking about? I mean, if I get in a car accident tomorrow and I'm taken to an ER here in France, you know, I know what kind of care I'd get. But how much experience had a Navy physician like that had at that point of the war?
Well, I think that's a good question. When we talk about the physicians who staff the battalion aid stations, that first facility, that first aid station where the patient will encounter a physician, those physicians are called battalion surgeons in the United States, but they are not surgically trained. Surgeon is a term used by the military to basically indicate any physician, any commissioned physician.
Right.
These young men at that time, now men and women, of course, but during World War II, they were exclusively men. These young men received an education in medical school for 4 years and maybe a year of internship, clinical training afterwards, and that was it. That was it. They were given some basic instruction in the military during their orientation, and then they were sent off, and they were on their own. So battalion aid station, the battalion surgeon may have had 1 or 2 years of experience after medical school and almost no surgical training. Now, surgeons themselves, those that the military considered true surgeons, had some level of surgical training, anywhere from 2 to 5 years. They did not have a standard training program as we do now in surgery. Now it's a 5-year program or more. In those days, in the early 1940s, late 1930s, it was extremely variable how long surgeons were actually under supervision in their training. So, but if you had any surgical experience at all, by the military standards, you are a surgeon and good to go. So it was sort of a variable how skilled some of these surgeons were. A few had passed examinations in the United States by the American Board of Surgery. That was some indication that they had a certain level of knowledge that should carry them through. And that was, those people, of course, were given advanced standing and some of the more cushy jobs, but they were more urgently needed at the front. Unfortunately, it took a while to realize that. So that's the deal with surgical training. It was extremely variable. Many of these physicians on board ships, such as the Sheridan and other attack transports, some of the LSTs, had no surgical training and were simply physicians. Now, that made sense because most of the problems on board ship were not surgical problems. They were mostly matters of hygiene, cleanliness, the common colds, the other kind of disorders that occur in young men at sea. So it made some sense to the military, but in times like this, with these amphibious operations, they were called upon to do extraordinary things.
I mean, the conversation in the sidebar are kind of essentially saying that it's on the job training. I suppose that's sort of it, isn't it? I mean, and I think of TV shows. I know I shouldn't talk about medical TV shows with a doctor because you probably hate them all, but things like Scrubs and those kind of things, where it always seems that your new doctors are sort of protected by that environment of experienced nurses and then previous and staff and registrars who kind of guide them through their first couple of years. It seems to me if in the military you are just sort of flung to some Pacific corner of the Pacific and it's pretty much all on your shoulders very, very quickly. But the positive is you're going to learn very quickly, I guess.
Yeah, and this was particularly true in the Pacific theater, as well as I'll talk about in a little bit. The European theater was much more orderly in that sense, in that the surgeons were identified early on and placed appropriately. In the Pacific, as you saw from my diagrams, there were no surgeons immediately available for some of these early amphibious operations in the Gilbert Islands and Marshall Islands and even later. So the doctors on board the ships with almost no surgical experience were thrown into the fray, and because of their ingenuity and their willingness to take on these casualties, did amazing work.
Yeah, well, we'll move on. So another nasty photo, folks.
Yeah, so again, I'm just trying to demonstrate when you see casualties portrayed in most movies and on television, they're fairly neat problems. There's a bullet hole here or there, and that is simply not military trauma. It is the wounds of war. Mortar shells, landmines, artillery shells are extremely mutilative. And you can see here one of the common problems that is seen, and that is an evisceration injury, a tear in the abdominal wall, and guts flow to the outside. And it's extremely intimidating for many physicians to see this. I mean, what do you do with it when you've had absolutely no experience dealing with it? And in this particular case, it seems to be just an evisceration injury. Much of the time, the bowel that has exited the abdominal wall is damaged, torn, bleeding, contaminated, and it's no easy matter to get it fixed.
We'll move on from the images.
Now, as the war progressed, I want to talk a little bit about the Mariana Campaign. Things changed a bit. The amphibious operations in the Marianas, particularly on Saipan, were against larger islands where there was an opportunity to set up field hospitals on shore and to send in what it was thought of as trained surgeons. If I could have the next slide. And this is in the summer of 44. So the campaign on Saipan, if you enlarge that a little bit, I've got the crosses indicating the actual field hospitals that were set up right around there. Those were the Marine field hospitals. And when you see down below the airfield there, there was a portable surgical hospital, one of Carroll's portable surgical hospitals, and a field hospital. In each of those locations, there were surgeons with some surgical training. So on shore now for these larger islands, and out of range of direct enemy fire, there were hospitals set up to deal with the casualties that were arriving from battalion aid stations and to deal with them in an effective and safe manner. So let me go to the next slide. This is an example of evacuation of casualties on Saipan, mostly by jeeps. They were loaded onto the back and the front and taken off. And you see on the right-hand panel, there's a picture of a field hospital on Saipan. You can kind of get an idea of how that was set up. This was a part of the hospital that was x-raying soldiers. You can see that they were loaded, they were on their stretchers, and the stretchers were taken from area to area and placed on some type of support, a table or sawhorses or something of that nature, and care continued. They were x-rayed, they were taken from the x-ray department, many times straight to the surgical area, on their stretcher, placed on sawboards or sawhorses, and surgery was begun. So, and you can see, I think, maybe some plasma hanging there as well. So the facilities on Saipan by the summer of 44 were a little bit more organized and a little bit more skilled. So next slide. And here's the field experience of a field hospital on Saipan. There was about 400, 500 beds. And during that campaign, they admitted 2,883 casualties. They had almost 800 surgical cases, 21 chest injuries, 21 abdominal injuries, where the case fatality rate was 50%, and 41 fractures. But amazingly, only 3% of these admissions died, which I think is a remarkable testimony to the skill of the surgeons, and more importantly, to the ability to get the patient from the aid station to the surgical hospital.
Wow. And just to inform you, Tom, we're getting some interesting questions. Trent Telenko is particularly asking about, he asked about the blood bank ship, LSTs earlier in the Saipan. He's asking about the whole blood plasma versus blood. Are we going to be addressing that? I don't know the answer to that, so I'm handing it to you.
No, I'm more dealing with the systems of care rather than some of the specifics. But I can tell you that whole blood was often utilized, and the way it was utilized was that people aboard ship were typed in advance, and when they needed type A blood or type O blood, they'd call the people that were type A and type O, and the sailors would lay down and give blood, and it was instilled into the casualty right away. And there is nothing more effective in stopping hemorrhage than fresh, warm blood, whole blood. So that was the preferred way to resuscitate if one was going to use blood. And like I said, they were live donors on the spot, laid down, gave their blood, and it was immediately instilled into the casualty. When that wasn't possible, and oftentimes ashore at battalion aid stations, of course, they could only give plasma, which was still effective. What the soldier needed more than anything was a plasma expander to fill their blood system and replenish the blood that had already been lost by the injury. So I hope that provides some help.
Yep, thank you.
So here we come to the Iwojima Campaign in February of 1945. You see the island, of course, everybody's familiar with that, and the invasion beaches. You see the Japanese airfields that were already constructed or near construction. So moving on to the next slide. So two Marine divisions assaulted the island in February. Horrific scene at the beachhead as the Japanese zeroed in on the troops as they piled up on the beach. Eventually the evacuation plan seemed to work. Landing craft carried the casualties from the beach to barges lashed to LSTs. The soldiers, or I'm sorry, the Marines at that point were sorted through the more serious injuries, then taken to the hospital ships, which were now being used. Obviously, the air was secured. The sea was basically secured, so it was safe to move in these defenseless hospital ships to aid in the resuscitation of soldiers. And next slide, I have a picture of the island. Once the Marines had advanced northward, the surgical hospitals came ashore. There were some Marine Corps hospitals and division hospitals set up, which were basically all what that amounted to were surgical field hospitals. They were staffed by trained surgeons, at least some degree of training, and they could provide care on the spot to casualties. And there were a great many of them, of course, during that amphibious operation. So we have a comment here.
Yeah, 13 million pints of donated blood.
Yes, and thank you for that comment. That's informative.
Yeah, there's a good crowd here providing information. As usual, folks, if you don't, when you finish watching the show, go back and read the sidebar, because there's some fascinating side conversations there. Again, people showing off their expertise and their wide-ranging knowledge. So I shall go back and read all that myself. But yeah, we're seeing the progression in terms of from Tarawa to Iwojima. We're seeing how things are getting better.
Yeah, and so and you see some pictures here of some of the field hospitals on Iwojima. Some of them are actually underground and not immune to occasional mortar fire and even sniper fire. Very courageous individuals who man these facilities, not only surgeons, but all the other personnel that made the whole operation work. So next slide. And then we have, of course, Okinawa in April of '45, a very bloody campaign. Again, though, a large enough landmass that at some point in time, and you see again signified by the crosses, at some point in time, it was safe to move ashore surgical hospitals to assist in the care of the wounded individuals. And I might add, starting with Iwojima and with the Okinawa campaign, air transport, now that there was fairly good control of the air transport was utilized to fly these people back to rear areas, mostly now in the Marianas after those islands had been secured and base hospitals had been set up. So from Iwojima and Okinawa, air transport was used almost on a daily basis to get these casualties off the island and back to base hospitals then located in the Marianas. So next slide. You see some of the operations on Okinawa. Again, the field hospitals in the lower panel there. The inner workings of and you see how they're still tented structures, but very effective. There were tents for operations and radiology and recovery, so they could hold anywhere from 500 to 1,000 patients. And you see to the right, right there, you see the use of air transport to load these casualties and get them off the island. So that was a big help in evacuation. So let's move on now. Example of a hospital ship that was used off of Iwojima and Okinawa. And if I go to the next slide, you can see an example of the operations done there. Here's one particular surgeon operating aboard the Solace off of Okinawa in 1945. And it looks now it looks like there is a standard surgical setup. Everybody's gowned and has gloves on, and it looks like they're in a real operating room, which in fact they were. So that was a big help.
And while it covers, Scott Grimwood, another regular, is asking about the effect of the tropical environment. I mean, obviously that's a consideration of Pacific, less so in the ETO. So clearly it was a factor. How did that influence things?
Well, it didn't have a big impact, but I can tell you from my readings that that it was extremely hot and humid on, of course, many of these islands and also aboard ship. There was no air conditioning, and some of these surgeons drip sweat onto their patients, and you might think, "Oh my gosh, that's set up for infection," but in fact, it really wasn't. So it was unpleasant for the Marine uh, uh, and the soldier. It was also unpleasant for the physician caring for them, but the impact on their eventual outcome was oftentimes negligible.
Cool.
So I want to move on briefly to the European theater in talking about this concept of damage control.
Yep.
Now, in the European theater and the Mediterranean theater, we're dealing with large land masses. We're dealing with the ability to move hospitals up to near the front. We weren't challenged by miles and miles of open ocean. So that this is more of a standard configuration of echelon casualty care. The medic in the field, the battalion aid station, the field hospital, referred to as a clearing company or clearing station, oftentimes surgical in capability, and the evacuation hospital as the next tier of care, and finally the base hospital, usually in England or sometimes even back into the United States. So that was fairly standard. Now, what wasn't standard at the start of the war was the nearness of the surgeon to the soldier. And again, it was very clear that in some of these campaigns in the European and Mediterranean theater, it was very clear the surgeon had to be closer to the soldier, that we could not rely on the limited expertise of so-called battalion surgeons or other medical officers who lack surgical training. And this, you could go to the next slide. Once this was in the form of what was eventually termed auxiliary surgical groups. This was the brainchild of Edward Churchill, whom we've talked about before, and another individual that you might recognize his name, Michael DeBakey, who eventually, after the war, attained fame as a cardiac surgeon. Both of them came up with this idea of bringing the surgeon to the soldier, and they called these auxiliary surgical groups. It was clear that any delay in treatment was detrimental to recovery. Skilled surgeons to the front as far forward as safely possible was what was needed, and this was for resuscitative or damage control surgery. They chose young but well-trained surgeons who had formed these teams and assigned to field hospitals. Now, these surgical groups were not hospitals in their own right. They didn't have their own tents and support personnel. They were basically strictly a surgical team of surgeons and their surgical assistants, sometimes surgical nurses, who would then attach themselves to field hospitals. That's why they were called auxiliary surgical groups. They were operational in North Africa, Italy, Normandy, and throughout France and Germany during the latter stages of the war.
So just another question for you, Tom, because I like jumping in.
Sure.
We're talking right now about the COVID issue and people saying that, you suddenly can't produce doctors and nurses out of nowhere, which makes sense. But given they had this, people mention the Spanish Civil War, people mention obviously things in 1939, the USA involved a little bit later in World War II. Was there any move in, for example, 1939-40 in the USA to try and get more people into medical school? Was there any kind of foresight in that we will need these people 4 or 5 years down the road? Because clearly, you're saying to get these young surgeons, they've got to come from somewhere. Was there a larger pool later on in the war because of forward thinking, or was it the same kind of numbers it always been?
No, there was no, as far as I'm aware, there was no organized plan to augment medical training. The medical schools were, their enrollment was basically set in stone. There was no ability to suddenly expand that. And it takes anywhere from 4 or 5 years to complete training, medical school training anyway. So no, there was no ability to expand and contract medical education based on military needs. That's a good concept, but that just wasn't operational during World War II.
So does that mean that I'm going down a potential rabbit hole now, but conventional hospitals in the USA during the war, were they understaffed? I mean, if there are that many more surgeons in the military doing all this stuff, was there a problem back stateside, or am I going down a rabbit hole that isn't worth discussing?
Yes, I think there was a drain on medical personnel as caused by the war. I don't have exact numbers on how many doctors and nurses were deployed overseas, but there were a substantial number, as you might imagine, especially those covering the base hospitals in the South Pacific and in England, and later in Italy, later in France. So, yeah, there was a drain. I don't think it was it ever dropped to a dangerously low level so that healthcare in the United States was jeopardized, but I think it was felt. Yes. Wow. A lot, especially in the field of surgery, a lot of surgeons, a lot of surgical departments were emptied.
But I guess the boost that would have happened post-war, I know the few surgeons I've read about in the 101st, what have you, the boosts to civilian medical science after war was enormous because of these guys coming back from, 2 years overseas. What they could bring back to hospital was immeasurable in the what they'd learned in that time. So I suppose it was a roller coaster in a sense of ups and downs, but I guess that late 40s period in the USA would have been fantastic with the developments brought back.
It was a major period in surgical history where there were inordinate numbers of surgical advances. You're right. They came back extremely skilled.
Anyway, I'll let you get back to your talk.
Yeah, and by the way, that comment, Michael DeBakey was one of a kind. I'll tell you, he was quite a fellow. So anyway, here's a picture, just again, of surgeons of the 2nd Auxiliary Surgical Group operating at Anzio. They were vital to that campaign in dealing with the numbers of wounded who could not immediately be transported offshore because of the besieged nature of that operation. So next slide. So here we come to Bastogne in December of 44, and here's kind of a wide panoramic picture of the town of Bastogne. It's sort of centered up in the left upper area, some of the roads leading to it. And that, of course, turned out to be a crossroads of the German advance through the Ardennes. They needed to get to Bastogne in order to disperse to the surrounding areas. And so it was vitally important that the United States hang on to that town, which they did via the 101st Airborne, which was quickly trucked in, and not parachuted in, but trucked in. So next slide. As part of the 101st Airborne, the 326 Airborne Medical Company set up a location a little bit outside of town in a field, and you can see it here, probably one of the last pictures of it. That was basically a field hospital. The surgeons of the 3rd Auxiliary Surgical Group were there, present, able to render surgical care. On December 20th, as the story goes, machine guns opened up, tracers tore through the canvas, the wounded laying on stretchers groaned as some were hit a second time with fragments. I remember thinking, so you've had it now. That was one of the auxiliary surgeons. The Germans stumbled onto the medical company basically by accident, overran it, captured all of the medical personnel. A few might have been killed and captured all the patients. And so what you had then was the entire capability to care for casualties by the 101st Airborne was gone. Yeah. Gone. No surgeons. They were encircled and they were without surgical care. And the siege began. Next slide. And what happened in some of these towns around Bastogne, as you probably know, the battles around Bastogne were not fought within the city. They were fought in these hamlets that surrounded the town by kilometers. The town itself served as a focal point for command and communication, but and as it turned out, for some makeshift hospitals. But much of the initial care of these injured soldiers was done at grimy little aid stations like this.
So, and we have a special program coming up on Wednesday about the grimy little aid stations in Bastogne. Reg Jans, the premier Battle of the Bulge Guide, has been around and taken footage, I think 7 or 8 of the aid stations around Bastogne. So Wednesday, folks, 5 p.m. UK time, Bandages in Bastogne is Reg's show about the aid stations in Bastogne. It's almost as if I prepared these shows with some kind of connection in mind.
Well, it would be a fascinating story. I'd like to hear that. So what are you going to do with these casualties? No surgical care. They're lingering now for days with their injuries. Their wounds are festering. And how are you, and at that point, nobody was certain Patton was going to break through. They could feature themselves in Bastogne indefinitely or eventually being overrun by the Germans. How are you going to get medical care in there? Well, next slide. Well, here's what happens first when you neglect wounds. This is a case of gas gangrene. This poor fellow, probably this is a fatal stage of the disease. You can see the purplish discoloration, the large blisters forming. This is a bad bacterial infection that is oftentimes fatal if not caught early, and it oftentimes occurs in neglected wounds that had not been cleaned properly and cared for properly. It was particularly prevalent during the First World War, but could be seen on occasion in the Second World War. So next,
we'll move on from that one. It's nasty.
Yeah. So what are you going to do with these casualties? Well, the plan was to fly in surgeons. There was one surgeon who was flown in the day before Christmas in a sort of like a Piper Cub, landed, unloaded his stuff, and ran in and began operating. The following day, gliders came in loaded with 4 or 5 surgeons, one of whom was a fellow by the name of Lamar Suter. He later became chairman of the Department of Surgery at the University of Massachusetts, distinguished career. He flew in. These guys didn't even know if they were going to survive the landing, for God's sakes. They unloaded their equipment under fire and ran into the command area of the 101st in Bastogne and began caring for casualties. Of course, the following day, the 27th, I believe, or 26th, Patton broke through and relief was at hand. But they didn't know that. They worked endless hours caring for the casualties that had accumulated. So remarkable story of a relief effort to get surgeons involved. So next slide.
Which is the last one, in fact. Yeah.
This is my summary slide here. What I want to point out is that World War II saw early surgical intervention that was imperative to survival, stop the bleeding, reduce contamination. There was an organized ability to get skilled surgeons to the front, both in the Pacific theater and via the auxiliary surgical groups in the European and Mediterranean theater. And there was a remarkable advance in the principle of damage control and resuscitative surgery. So those were sentinel events that occurred in the surgical narrative of World War II.
Well, thank you very much, Tom. I've got just a couple of questions before I let you go back to your surgery and carry on with your work. But one was sulfur powder, because in our test we talked about that, because all the medics are equipped with all soldiers have with them a first aid kit, a bandage with a sulfur powder. You were saying something in the pre-test about it not perhaps being as effective as people thought. It was almost like a placebo thing. Kind of set the record straight on that.
No, it really had no immediate impact on the wound. People thought it might because it was a topical antibiotic, and antibiotics are good to kill bacteria. But basically, putting it on the wound did more for the medic, the corpsman, and the patient than it did for the wound. So, but it's important that the injured soldier or Marine know that something is being done. It has some kind of psychological effect that I still don't believe we appreciate or understand. So anything done to the soldier is good for their morale. It's good for the corpsman, the medic, and it is just good for overall morale.
Absolutely, and I think the morale aspect will come into the show with Dr. Lee Mandel on Wednesday evening when we talk about combat stress and what would now be labeled PTSD. The morale, that mental health, that's all part of it as well. But my final question, for which I apologize in advance, is kind of potentially a big one. But when we talk about the military campaigns of World War II, the ones we discuss endlessly, I'm thinking Arnhem, I'm thinking Midway, I'm thinking Iwojima. As a doctor and military historian, do you think your average military historian pays enough attention to the medical side of the things? You know, when we're talking about the fine balance between a side winning a campaign and losing a campaign, we talk about logistics, we talk about engineers, we talk about air power. Is the medical procedures of a nation or in a campaign discussed enough in those kind of works, do you think?
Well, I don't think it is by the lay audience. I think there's plenty of discussion among medical professionals, and certainly extending to combat medics. I just, I think it's not a very pretty subject, because that's where the true horrors of war show themselves. The mutilation and the damage and the loss of life that occurs, the suffering, the pain, is a very sobering subject, and it takes a lot of the intrigue out of war. I mean, you almost wish it would never happen again.
Well, absolutely, and that's the thing. That we can literally measure armor thickness and say this tank has more protection than this tank. We can look at the capabilities of weapons and say, oh, aircraft, this flies faster than this one, and we can make those comparisons. But talking about, in a sense, the well-being of an army is such an abstract concept. It's hard to kind of look back at World War II and say, did America's advanced medical systems give them a 5% advantage in battle? I mean, it's impossible. You can't make a statement like that. But I think it's definitely something in my reading about campaigns, I've neglected to think about the importance of the role of doctors and surgeons in that keeping of an army functioning. And I'm glad people like yourself, bringing it back to your book there, has addressed some of these issues and get us to think about some of this aspect, because it's something that I think we who talk about aircraft all the time should talk about medicine more. And I think perhaps we'll bring you back on in a future show and talk about specifics of combat injuries or wounds. This is an overview starting point, but people enjoy it and watching it have enjoyed it, so that's good. But I'm aware of the fact you've got to get back to work and do your day job. But thank you incredibly much for joining us and sharing your knowledge. It's really important that we have a doctor talking about this, not just someone who's read about the archives or hospitals. All my other presenters this week, well, no, Lee Mandela was a Navy physician, but they're kind of the military historian side of things rather than the medical historian. So it's important that we got started off with yourself there. So I will just say to the folks we've got coming up, and I'll come back and say goodbye to you in a second. So don't forget, folks, as usual, the link to Dr. Thomas Helling's website is in the description below. The link to his book is in the description below. Check out what we're doing on social media. Don't forget to share things on Twitter. Consider becoming a patron. We've got 5 more shows as part of Medics Week coming up for you. Just check out on YouTube what we've got coming up. In terms of what for today, it remains me to say thank you very much, Dr. Thomas Helling, for joining us. Did you enjoy it?
I thank you for having me. Well, it was a wonderful experience.
Well, it's I think it was important, and I'm really glad what you did. So again, thank you for watching, everybody. I will see you all again same time tomorrow for the next show, which is about a Japanese doctor and an American soldier at war in Attu, which will be a fantastic show. Storm on Our Shores is tomorrow's show. Then we have Reg Jan doing about Bastogne on Wednesday, Dr. Lee Mandel talking about PTSD, and the rest you'll see as they come up. So thank you very much, Tom, for joining us. Thank everybody for watching. I will see you all again tomorrow. This is Paul Woodhouse for World War II TV saying have a good day. Thank you for watching.